My name is Dr. Ron Wells. I'm relatively new here, having just joined Prisma in August. And as a pediatric cardiologist, I'm happy to be here. And I was asked to give a talk today, but I think everyone probably knows the topic already. But rather than start with a title slide and things, we'll just jump in with a case. And I just realized I need to close my door here. Hang on one sec. I wish we were doing this in a large group setting because it'll be more difficult for me to kind of get the nonverbal feedback from you all since I'm sitting by myself in my office, but I think this will work out reasonably well. This is a real case that I wanted to share from my previous hospital. Changed it a little bit to make sure I've anonymized it enough, but this is I chose this because it illustrates some of the challenges that we find in Kawasaki disease. I've given it away. And so we'll just jump right in here. So this was an 8-year-old girl who was previously healthy and came to see one of the general pediatricians for, at that point, what had been 11 days of fever ranging anywhere from 101 to as high as, by report, almost 106. Started fairly abruptly, and she was also experiencing some myalgias and fatigue. On day one, she, in addition to the fever, she had some eye complaints, mostly sensation, not how they looked. Day two, she developed a rash that was sort of central, started on her legs and moved up to her abdomen and torso. She was seen in urgent care on day 3 of fever, where they checked a urinalysis and checked her for flu, neither of which were very revealing. The rash spread and now involved hands and feet by day 4, and she went to an emergency department on day 5, where now the rash included her cheeks, and they said she had a slap cheek appearance, probably parvovirus, and did check a strep, which was negative. On day 5, she also had some non-bilious and non-bloody emesis. As far as background, this was a well girl, as I mentioned. She'd had a heart murmur noted at some point in the past. She'd never had any surgeries. She doesn't really take any medications, although now she's had some antipyretics. She doesn't have any allergies. She lives in the Puget Sound area with her biologic parents. She has 2 siblings. Everyone is healthy other than her complaints. And she hasn't recently traveled, specifically no camping. So at this visit on day 11 of the fever, she continued to complain of eye complaints. She now had a sore throat. For pertinent negatives, she didn't have any cardiac symptoms, no chest pain or palpitations. She'd not lost consciousness. She continued to complain of the muscle aches and this rash. So have been pretty consistent features of the illness for all 11 days now. On exam, I honed this down to just include some of the pertinent findings, both positive and negative. You'll note that she's febrile and tachycardic and a little hypertensive, but probably within keeping for her fever and her unwell state. She was not toxic appearing and did not have any cervical lymphadenopathy, but they did note faint lateral conjunctival injection without exudate and moist mucous membranes. Lungs were fine. She was tachycardic as noted, but otherwise unremarkable cardiovascular exam. Liver was not enlarged. And indeed, she had a faint macular rash on both of her arms and erythematous cheeks. There were no oral mucosa findings. So this is where it gets a little tricky. What are the thoughts from the field folks thinking of? You can unmute and say it or type. Or I'll just move on. What would folks do next?
Oh, sorry, we just got to the mic. So we were thinking, obviously Kawasaki's, but maybe Miss C, even COVID.
Yes.
I think Miss C is something that we've, especially with the conjunctival injection, is something that we've really been thinking a lot of. And I'll let someone else answer what we'll do next.
Excellent points. All right. What would you do next? Again, I'm open to text comments or unmuted mics. What do you think we should do next in the workup? And this is not a guess what I'm thinking. It's pretty straightforward. Labs, anyone? We went ahead and did some labs here, and you'll see that, again, I've highlighted the things that were abnormal. She was had an elevated white count there at 23 with a neutrophil predominance. She was borderline anemic and had elevated platelet count there at 433. Basic metabolic panel was pretty unremarkable. But her inflammatory markers, both the CRP and the ESR, were pretty profoundly elevated, as was, she had an elevated procalcitonin, which was, I don't know if they use that here a lot, but we were kind of using it to as a additional indicator of sepsis or serious infectious type issues going on. Her urinalysis did in fact have some white blood cells in it, as well as a little protein. And some of the things that we'll talk about here as alternate reasons for some of the symptoms and signs that she was displaying were negative. So she didn't have mono, and her respiratory biofire panel was negative. That's the respiratory panel looks for influenza and RSV and things of that nature. All right. Is there anything else anyone would want to do at this point? A cardiologist is giving you this lecture. So you're right. We went ahead with it. Yes, of course. So we did an echo, and I'm just going to show you the pertinent still shots. The left coronary artery was normal in appearance as well as dimensions. The right coronary artery was normal in size. You see the little markers there. It measured about 2.1 millimeters. But notice how, and this is again where it's difficult. Let's see. If I move my mouse, can you see it? Hopefully so. Yeah, someone shake your head. Good. Look how this is the coronary artery that I'm pointing to here. And look how white the walls are, how in a sense, it's pretty easy to see the coronaries. And I will tell you from experience, a lot of times coronaries are not easy to see. We have to kind of hunt to find them. So when you see them easily, in a way, that's kind of a red flag. So we were concerned about the potential that this was an indication of air inflammation in the walls of the coronary artery. So in summary, at this point, we had an 8-year-old previously healthy girl who we have now diagnosed with incomplete Kawasaki's disease based on 11 days of fever, as well as at least 2 major criteria for Kawasaki's in the form of a rash and her eye involvement, albeit subtle, and then some supplementary findings in terms of the labs that we already reviewed, as well as the echocardiogram that showed what we call ectasia in her right coronary artery. So with that, I want to jump into sort of the more lecture aspect of today's discussion. And I will right off the bat tell you guys that this talk from this point forward is essentially directly taken from the American Heart Association scientific statement that was published in Circulation 2017. You see the reference down there at the bottom. On the diagnosis, treatment, and long-term management of Kawasaki's disease. If you are a pediatrician or a pediatric resident and don't already have this paper electronically or in hard copy, I would highly recommend you get it. I believe it's freely available. They make some of the position statements and things at AHA available free even without subscriptions, although you should be able to get it through the library too. This is very important because this is basically the current state of the recommendations for Kawasaki's disease. So it starts out with a discussion of the epidemiology, talks about the fact that the incidence in North America is about 25 cases per 100,000 children per year. This paper is, of course, North American focused, but it does also reference a lot of experience out of Asia, where there is a lot of experience with Kawasaki's disease. So some of the stats here are kind of Asia oriented, and some reflect our experience here in North America. Risk seems highest in children of Asian descent, particularly Japanese ancestry, although any ethnicity is potentially at risk for Kawasaki's for unknown reasons. There's a slight male preponderance of about 1.5 to 1 incidence. I'm not sure that we understand that, and but I do feel like I've seen that question on the boards for those who have that type of thing coming up. So just kind of tuck that away. Males seem a little more predisposed to Kawasaki's. It predominantly affects young children, but I have seen myself a 13-year-old with it. He was a otherwise medically complex kid, former preemie, and size-wise, he didn't seem like a 13-year-old, but chronologically he was. So I could never quite understand if it was what it was, but he definitely had Kawasaki's. We do not know, as we'll talk about in the subsequent slide, what causes Kawasaki's, but there is at least a hint that it's potentially related to some kind of infectious etiology, in the sense that it has a seasonality to it. Specifically, it sort of tracks with the respiratory season, and more commonly we'll see Kawasaki's in winter and early spring here in the Northern Hemisphere. Recurrence rate in Japan is quoted at about 3%. But interestingly enough, I thought the more important thing was that the relative risk in a sibling is about tenfold if there's been an index case in the family, which speaks to a genetic predisposition. Case fatality rate is listed in Japan as less than 0.1%, and here it's fairly similar because we have a high index of suspicion for it and we catch it. If you don't, the complications and lethality of Kawasaki's does go up. Coronary artery aneurysms from Kawasaki's actually account for about 5% of acute coronary syndrome in the less than 40 population, which is not insignificant. I'm not going to go through this table here, but again, I've already alluded to the fact that we really are not entirely certain what causes Kawasaki's, but more than likely it's the sequela of an infection, not the infection itself, in a otherwise underlyingly genetically predisposed individual. And that sounds an awful lot like what we're seeing with coronavirus 19 and this MIS-C. And I'm not really going to talk a lot about that in today's lecture, but you will not be able to escape noticing some parallels and similarities. But Kawasaki is a big enough topic in and of itself that I'm going to try and just stay focused on that. The classical presentation, and this is straight out of the paper, and I did that on purpose because I think honestly on the boards a lot of times when they do provide illustrations, they come out of the seminal papers from the literature, it's kind of as a test to see if you've looked at them. So this is the illustration of the classic features. Actually, excuse me, this picture did not come out of the paper I referenced, but the next one does. There's the fever is actually not one of the criteria. It's sort of the underlying, it's the foundational thing. You have to have a fever for at least 5 days and 4 of the following 5 clinical criteria, which is, I just start from the top and move my way down is how I like to try to remember them. Conjunctival injection without exudate. Mucous membrane findings, which tend to be red, dry, cracked lips, and then also an inflamed tongue. People describe as a strawberry tongue. cervical lymphadenopathy, oftentimes unilateral and greater than a centimeter. Rash, which can be pretty much anywhere on the body and just about any kind of rash. And then changes in the hands and feet, particularly redness as well as swelling. Now, a lot of people jump to the peeling as well, but it's worth noting that the peeling is a finding that you'll see about a week or two in. And so if you're waiting for peeling as one of the skin findings or extremity findings of Kawasaki's, you're waiting too long. So please remember that, yes, Kawasaki's patients peel, but don't wait for that to make the diagnosis, and don't say, well, they're not peeling, it's not Kawasaki's. All right. This is the picture that literally comes straight out of that circulation paper, illustrating the rash. And again, it can be just about any rash. The conjunctival injection you see without an exudate. You see the strawberry tongue, a good classic picture there with the dry cracked lips. You see hand and then feet swelling there with also some erythema, and the cervical lymphadenopathy. I wish they hadn't included the two imaging pictures there because they're illustrating the aneurysms that one can see, but those are not part of the diagnostic criteria. It's these physical findings in the actual photographs that you want to pay attention to there. All right, I've already alluded to incomplete Kawasaki's disease with our case. Let me just move this here. Sorry. And that is that this established criteria for Kawasaki's that I just went over, unfortunately, does not identify all children with the illness. And in fact, in my experience, we don't use the term atypical Kawasaki's anymore. We try to use the word incomplete, but I have to tell you that atypical Kawasaki seems to be typical to me. And by that, I mean, every case always seems to be challenging to sort out initially. But as a mentor of mine once said, if you're starting to think about Kawasaki's, it probably is. We can be a little more thoughtful than that. But the point is that have a low index of suspicion for it, especially because not everyone's going to follow the book. So Kawasaki's disease should remain a consideration in your differential for any child with a prolonged unexplained fever and any of the clinical features, even if it's not all 4 of the 5. Basically, this slide reiterates what I just said. If they have a prolonged fever and clinical features, at least keep the possibility of Kawasaki's disease in the back of your mind. If in the course of the workup you obtain an echocardiogram and coronary artery aneurysms are identified, that pretty much rules in Kawasaki's. Although in today's era, it might also, rule in cardiac effects from COVID, but again, there's a lot of overlap. The flip side, though, is something that I want to make a point about, and that is that oftentimes the coronary artery dilatation is a later finding. And so just because you have a negative echo doesn't rule out Kawasaki. So we can help you confirm it, but we cannot always help you with the rule out portion. And try to avoid significant delays in diagnosis, which are often seen in the younger patients. The children under age 1 tend to do worse, and particularly under age 6 months, probably a lot of times because their signs are subtle and they get missed or delayed. Reiterating that point, incomplete Kawasaki's is the version you often see in infants, and they are at risk for developing coronary aneurysms. Again, maybe in part they're more at risk inherently, but also because maybe their treatment begins later. Sometimes they just show up with fever and irritability, and the other criteria are pretty subtle. That said, the lab findings and the cardiovascular impacts seem to be fairly similar in the full complete version versus the incomplete. So it remains just as important to pursue and make the diagnosis when it's appropriate. This table, if you haven't seen it already, you will in residency and you will use it regularly. It comes out of that paper and it is gold because you just follow this algorithm and it's going to help you tremendously. Any child that's had a fever for more than 5 days, or at least 5 days, and has 2 or 3 of those criteria, not 5, but 2 or 3, and you're starting to wonder, or they're an infant that's had an unexplained fever without other etiology found for greater than a week, you'll want to get some lab tests. And I went ahead and pulled out on the margin here what those lab tests should be, because they list them by their results and what the implications are. But I just, for writing your orders, get a CBC with diff, a CRP and an ESR, a comprehensive metabolic panel, and a urinalysis. You may get other things to help assess against for things in the differential as well. But at least these 4 or 5 things you'll want for the Kawasaki's evaluation. If the inflammatory markers are high, you stay on that right side of the chart there, and you look for the other ancillary findings, such as anemia for age, which this girl that I presented a case of was kind of borderline in that regard. An elevated platelet count. Again, this girl that we saw had 433, so she didn't meet the 450, but maybe she would have if we checked earlier, because we were on day 11 at that point. Hypoalbuminemia, as well as elevated ALT or other hepatic tests, and elevated white count. On the blood are important. The other thing that will almost inevitably show up on your boards is sterile pyuria, or white blood cells in the urine without evidence of infection. So no bacteria, but lots of whites. Sterile pyuria is kind of a clang association with Kawasaki's that you'll want to tuck away. So that is all very helpful lab information. If you get 3 or more of those positive in the setting of an incomplete suspected Kawasaki's, you would go ahead and opt to treat. Notice that if you have a positive echocardiogram, you'll still have had the labs, but the positive echo sort of trumps the findings regardless. But that said, and I put it in the margin and it's on a subsequent slide as well, because this has come up, don't delay your treatment because you can't get an echo for whatever reason. For example, if once you've left residency, you're out in an outlying clinic and you have the capacity to treat, but not necessarily get an echo, everything else is pointing towards Kawasaki's. Don't hold off. I've seen that a time or two where people are like, well, we couldn't get the echo, so we weren't sure, so we waited, and everything else said it was Kawasaki's, the echo's obtained, and it's not normal. And you're like, we've the cat's out of the bag now, but we will still treat, but don't delay. If those lab tests are ambiguous or reassuring, then you don't quit. You just keep re-evaluating serially, and hopefully things declare themselves. So in summary, keep Kawasaki's in the back of your mind. If you've got an infant less than 6-month-old with prolonged fever and irritability, or any infant with prolonged fever, and you've been thinking about meningitis, for example, but it's aseptic and still really doesn't have a great explanation. Infants or children with a prolonged fever and a shock-like picture, but they don't grow anything. Infants or children with fever and lymphadenitis cervical that doesn't seem to get better with antibiotics. And you can read the rest, but basically keep your antenna up. Things that you might also consider, and we always have to think about differentials, don't we, is that although people should be vaccinated against measles, not everyone is. And that rash that they put in the AHA paper could very easily have been measles as well. Other viral illnesses can present very much like Kawasaki's. Though it's important to remember that having a concurrent viral illness doesn't rule out Kawasaki's. So just because you identify parainfluenza on the rapid panel, but their case otherwise fits Kawasaki's, doesn't mean you don't have it, if that makes sense. So consider these as alternative explanations, but not necessarily ones that'll completely off-ramp you from the Kawasaki's diagnosis. Group A beta hemolytic strep can have features that overlap with Kawasaki's, and a urinary tract infection in an infant could potentially look like Kawasaki's and vice versa. And specifically, you get the febrile fussy infant, you check the urine, there's lots of whites, you assume it's a UTI, you treat, but things don't get better. That very well could be the sterile pyuria that we were talking about, and it's actually Kawasaki's incomplete. Same thing with the meningitis. It's a good thought, always think of it. But if it's not following a typical pattern, maybe it's white cells in the CSF in the absence of an infection, and it's actually, again, Kawasaki's. I didn't say it yet, but really the thing to remember is Kawasaki's isn't a heart problem. It's a systemic vasculitis. And the vessels that, when affected, are probably the most troublesome are the coronary arteries, but you're getting inflammation everywhere. And that's why you're seeing it in the urine and potentially in elevated hepatic enzymes, et cetera. Other things that you can see that aren't necessarily part of the diagnostic criteria, but you can look out for is frank myocarditis, pericarditis, and valvular regurgitation. I've not seen that in Kawasaki's, but it's possible. The coronary artery abnormalities that we talked about, and aortic root enlargement. This girl I presented had the arthralgias, or at least the myalgias, which again are not a criteria, but go along with it. And she did have the some of the nonspecific GI in the form of vomiting as well. One thing I'll note is that under nervous system, you see extreme irritability. Anyone who's been doing peds for a while will agree. These kids, often toddlers, are just very, very upset and very much out of character. Parents will tell you, well, this is normally a pretty laid back 2-3-year-old, and they're just miserable. I think they feel poorly. They probably have a headache. And the contrast, once you've identified and treated them, the almost miraculous turnaround to the previously happy, healthy child that they once were, really underscores how irritable they are when they show up. So it's not part of the criteria, but I'll tell you, keep your antenna up when you see the really uncharacteristically irritable toddler. And there's other features that make you think Kawasaki's. Right, I think that's enough on this slide. Treatment, we'd be remiss, of course, to not discuss that. I pretty much took these right out of the paper, so forgive all of the words, but I left them on there for comprehensiveness, because I'm assuming these slides are available subsequently. The treatment is high dose IVIG, and it's 2 grams per kilo. You give it as a single IV infusion, but it takes overnight pretty much. And so it's not given like as a bolus. And ideally, it started within the first 10 days of the illness. So you're, of course, not going to give it before day 5, because by definition, you can't make the diagnosis before day 5, although they say you can on day 4 if you're an experienced person with Kawasaki's disease, whatever that means. So really, you're talking about this fairly narrow window from day 5 to 10 of fever, where you'd like to catch them, because that's when the studies show us you're most likely to have a positive impact in terms of reducing the likelihood of coronary artery aneurysms. That said, it is reasonable to go ahead and administer IVIG to a child who presents after day 10, like ours, who presented on day 11, at least to us, if there are still signs of ongoing inflammation, such as persistent fever or elevated ESR or CRP. You would also co-administer either moderate or high dose aspirin. They tend to use moderate dose in Europe, and the high dose 80 to 100 milligrams per kilo per day, divided every 6 hours, tends to be more what we use here in the United States. It's not clear if one is better than the other. That is added on in addition to the IVIG, and it is carried on at that high dose until the patient's been afebrile for anywhere from 48 to 72 hours. There's no good guidelines, but that's kind of a range that most people follow. I must point out, the aspirin does not reduce the incidence of coronary aneurysms. That's the IVIG. That's definitely been shown. But you do want to use it because it's anti-inflammatory and it inhibits platelet aggregation. And if you do have coronary abnormalities, you can get thrombosis in there. And that leads to its own set of trickle down problems. And so the aspirin is anti-inflammatory and antiplatelet. The flip side to the IVIG after 10 days is that if the patient has shown up and has a history that sounds like it was Kawasaki's, but their signs of inflammation have resolved, they don't have fever anymore or signs of significant elevation of their inflammatory markers, you would not at that point treat them with IVIG just because it's probably too late at that point. Worth noting that the ESR will be elevated by IVIG. So at that, once you've given it, you can't use the ESR to track response to therapy in by itself. Once they've been afebrile for 48 to 72 hours, you're not going to stop the aspirin. You're going to switch to low dose, which is 3 to 5 milligrams per kilo per day. And you're going to do that until about 6 to 8 weeks out from the onset of the illness. Remember 6 weeks, and you'll see why in just a second. 6 weeks is a good number to remember. Little side note, 2 side notes really. It's in the paper and most people forget it, but you should try to avoid using ibuprofen when you've got the patient on aspirin because it kind of works against the antiplatelet effects. And of course, ibuprofen is one of the things you may be reaching for because this is a febrile patient. So try to remember, just avoid ibuprofen in the acute treatment phase of Kawasaki's disease. The other thing is if you give IVIG in high dose, you want to delay the MMR for 11 months after that. If after the first course of IVIG, they still have fever or they defervesce, but then it recurs, that's considered IVIG resistance. Typically, I just recommend that you do a second dose of IVIG, a second course, but it's, and after that, involve pediatric rheumatologists, but it's not entirely unreasonable to start potentially considering getting them involved in the conversation because some of the more advanced treatments are really more in their lane, the infliximab, cyclosporin, et cetera, that you see here. I'm not going to really delve into these. Steroids is controversial. Some folks think that it is a helpful addition in the treatment of Kawasaki's. Most do not think it's helpful or advised, but it is listed here as an option in IVIG failure or resistance. So in other words, failed to respond completely after just 1 dose. Recommendations for cardiovascular assessment, which is basically echocardiography during and after the acute illness, is that it should be performed if the diagnosis is being considered. But again, if you can't get an echo, don't delay treatment if everything else is pointing towards Kawasaki's. This is on us, point number 2. Coronary arteries, obviously, everything's important, but the coronaries are probably the focus. And importantly, we want to actually measure them, not just look at them. A lot of times when we're looking at kids for other reasons, we'll say coronary artery origins appear normal and normal proximal course. We don't actually measure them every time, but this is a time when actually making measurements matters. And you want to, of course, do a Z-score. So you're adjusting the raw measurement for the child's body surface area, and there's tables that give us what's normal so we can tell if they're enlarged or not for the child's size. If they're uncomplicated, which is pretty much no or minimal coronary involvement, we'll want the echo to be repeated at 1 to 2 weeks and 4 to 6. There's that 6 weeks again. I like to have them come back. I'll see them at 2 weeks out from the illness and 6 weeks out, because if at the 6-week visit things are good, that's when we can discontinue that low dose aspirin. And so there's, in my mind, there's, if you wait longer than 6 weeks, you're out longer than the recommended follow-up. And if you come in too soon, you're going to stay on aspirin until we check you again anyway. So 6 weeks is just like a perfect sweet spot to bring them in for that second reevaluation after the initial illness. Obviously, if there's coronary abnormalities, then more frequent echocardiography is going to be indicated. And I'll just let you read those on your own later. We're in the last 3 slides now, and I think that one of the really helpful things about this updated guideline in 2017 versus the one that came before it, which was about 10 years prior, is that they classify cases into they risk stratify basically. And I do not have these completely memorized, the 3.1, 3.2, et cetera. But basically, one is no involvement of the coronary arteries at any point during the illness. Two is they were dilated, but the Z-score, or number of standard deviations above the mean for the body surface area of the child at the time, was above 2, which is considered enlarged, but below 2.5. So mild dilation. 3 is a small aneurysm, 4 is a medium, and 5 is a large. And you can read the subcategories there on your own. The importance of this classification system is the next 2 slides. And that is that once you have the risk level, you just go to this table 10 and then table 11 for your long-term follow-up counseling and treatment algorithms. So you can see right there at risk level 1, where the coronaries, they had Kawasaki's, but the coronaries were always normal. They can be discharged from cardiology follow-up between 4 weeks and 12 months. Again, my 6-week follow-up is perfect because I'm after 4 weeks, obviously well below 12 months. And I can see them, if they're normal, discontinue the aspirin, and I can actually be discharged from follow-up with me at that point. Although a lot of times I'll just go ahead and err on the side of caution and say, let's see you in a year at least. Not a lot of additional testing necessary. And again, I'll leave the rest of this table to your own perusal if when the need arises. It was very helpful because it pretty much talks about everything, including physical activity restrictions, if any, cardiovascular risk factor counseling, et cetera. I would note that you'll see the cardiovascular risk counseling is actually an pretty much all the risk levels, but it doesn't necessarily need a cardiologist to do those. And that's what one of the footnotes said. So it's a partnership between us and general pediatrics, this follow-up. The last table, again, is table 11, and it talks about whether they need long-term treatment or not. So you can see, again, low-dose aspirin stop 6 to 8 weeks out if there's never been any coronary involvement. You can carry on a little further if there's been dilation. They don't need further anticoagulation, et cetera, until you start to get up into the small, medium, and large aneurysms. That is the last slide. Do I have any questions? Looks like we finished pretty much on time, maybe a little early.
I think there's a question in the chat box.
All right, let me see. From the call room to everyone, for serial lab monitoring, how frequently do you obtain those labs? Which serial lab monitoring? Like if you're on the incomplete algorithm and the labs are ambiguous, when do you follow up? Is that the question?
Yeah, it was on the slide where if you weren't, that one where they didn't meet the criteria. So yeah, that one, exactly.
How often?
Mhm.
I believe in the paper itself, it actually addresses that. And of course, for slideology purposes, I didn't include all the fine print, but I think they actually talk about that. I probably recheck, like, I don't know, let's say it's you saw the kid in clinic, you weren't sure, they get admitted, you've got labs for the night evening, maybe check again in the morning. So like a Q12, if the paper does not provide any further concrete guidance on that. I do not know off the top of my head. That is a good question when it just says serial reevaluation.
Yeah, I guess the question was, is that enough to admit just for, Q12 lab monitoring? And then if everything's good, like an overnight observation thing, or could you discharge from the emergency room with those findings if the CRP and ESR are below those numbers?
That might have as much to do with your confidence that the follow-up is reliable.
Purely followed outpatient.
Yeah, if you were, well, I'm going to be careful here because I don't want to be like, well, Dr. Wells said, let them all go. But, I think if you got these inflammatory markers and they truly weren't elevated and nothing else was, of course, obviously pushing you towards admission, like they clearly have UTI or something needing parenteral antibiotics, and you knew they'd come back. You probably could see them the next day if, you know, if you were able to do that. If they were, it sounds a little case by case. If, you know, you weren't sure about the follow-up and you wanted to make sure they were a captive audience, or it's one of those young ones under 6 months or even really under 12, where you know that the cases can be pretty ambiguous and you want to be sure you don't miss something. I always ask myself before an admission, what is it that I'll do inpatient that I can't do as an outpatient? And maybe sometimes the simple answer is ensure the follow-up or the monitoring. That's kind of a wishy-washy answer, but I hope it's not too far off. Any other questions? Well, I think we actually may have finished a little bit early, but I doubt anyone is too disappointed about that. I look forward to interacting with you all in person. And if there is nothing else, I think we can call it a wrap.
Thank you so much.
You are welcome. Good to be here.